Welcome to Robert Wood Johnson University Hospital's Health Talk. I'm Dr. Douglas Ashinsky of Robert Wood Johnson Physician Enterprises, Warren Internal Medicine. Recent celebrity suicides have drawn attention to mental health and the stigma that still exists, which prevents individuals from seeking the help they need. 1 in 5 adults in the United States experience a mental health condition each year, and 1 in 17 lives with a serious mental illness. Recovery is possible if individuals seek prompt medical care. On today's show, we will learn more about the common types of mental health illnesses, including depression and anxiety, and how to get help. We are joined today by our special guests, Dr. Jaspreet Uppal, Medical Director of the Behavioral Health Services at Robert Wood Johnson University Hospital, Somerset; Richard Wagner, Clinical Supervisor of Behavioral Health Services at Robert Wood Johnson University Hospital, Somerset; and William Semon, Clinical Supervisor of the Crisis Center in the Emergency Department of Robert Wood Johnson University Hospital, Somerset. Thank you for all coming. Welcome to the show. What we're going to start with is most people want to know a little background about yourself. So we'll start with you, Dr. Uppal. Tell us a little bit about who you are and what got you involved in behavioral health and mental health.
Sure. My interest really started as a medical student in rotations, understanding that someone could be physically fine, but still be reporting not doing well, still reporting this void in their life. A lot of times, family members asking them what reason they would have for feeling the way they're feeling, and they're realizing that there didn't really have to be a reason. And then really overall understanding that someone can be physically fine, but if their mental health is not what it needed to be or what it should be or what we would call healthy, that the physical health didn't really matter, that they still seem to be in this state of, despair or sadness. And that's what really drove me to the field of mental health, because it wasn't something that we can simply just get a blood test for and determine what was going on with the person, that you really have to get to know the person all around to get an understanding of what was going on with that person.
And your background?
I graduated from East Carolina University with my degree in psychiatry residency, and I've worked for the VA before. I've worked for other inpatient facilities in New Jersey before joining the Robert Wood Johnson family.
And?
Richard Wagner. My background, my education is I have a bachelor's in psychology, master's in social work. I'm a licensed clinical social worker. How I got into mental health was during college. I was going through some personal issues and saw a therapist, and the help that I received from that individual just changed my life completely. And so then and there, I knew that that's what I wanted to become and be the same.
And?
William Semon. I have a bachelor's in psychology and a master's in clinical counseling from Fairleigh Dickinson University. I'm a licensed professional counselor. I came into mental health through being in college. I was originally an early American history major and then had to take a required elective, ended up taking psychology and fell in love with it. And from that point on, just moved, been worked in many different settings, inpatient, outpatient, and my area of study and practice is crisis intervention and trauma.
As we know, mental health is such an important part of life. As a primary care doctor, half the time people come in, it's really for mental health conditions rather than other conditions, and the problem is it's the somatization of the mental health that gives them their symptoms. So tell us a little bit about mental illness and the most common types that we now see: depression, anxiety.
The most common mental illness in the United States is anxiety. We have about 60 million people every year that are diagnosed with anxiety. Depression also is very common as well. Every year you're looking at about 16 to 17 million that would actually meet the criteria for what we call a major depressive episode. And a lot of these folks are going undiagnosed. We talk about some of the more basic symptoms, but significant symptoms nonetheless: sleep problems, appetite problems, not having an interest in doing things that you want to do anymore.
As a primary care doctor, many of us do mental health screens such as PHQ-2s and PHQ-9s, which again hopefully bring out some of those mental illness problems. So we do ask the questions about, are they sleeping? Are they feeling down? Are they eating more or eating less than they should be? Are they not having the pleasure in life that they really should have? Do they feel as if they'd be better off dead or hurting themselves? And again, the big concern about both depression and anxiety is that. You want to talk a little bit about that?
Absolutely. Those are the symptoms that a lot of times can go unrecognized for a while. Somebody may just look at it as being in a bad spot for a few months. But what we know is that if you're having those symptoms or any combination of some of those symptoms, what we usually call it is SIGI CAP, right? So SIGI, S being decreased or increased sleep, as you referred to, a decreased interest in doing things that you enjoy doing. So if someone enjoys hiking, they're not doing that anymore. They're staying inside the house. They don't want to do that type of stuff anymore. They enjoy hanging out with friends. Friends call them and ask them to come out, but they don't want to come out anymore. So that would be the interest part of it. That would signify also that maybe there's something going on. G we refer to as guilt. Sometimes people feel guilty about something they may have done earlier in life or recently, maybe about their behavior. E, energy, decreased energy. Someone who's spending all day in bed, someone who's not getting out of bed, someone who's not feels like they don't have the strength to shower on a daily basis or frequently. CAPS, C being the concentration, decreased productivity at work, not having the ability to concentrate on what you're doing, getting in trouble at work. As a result of that, not wanting to go to work, missing days at work. A, sometimes appetite. You can see both. You can see increased appetite, you can see decreased appetite. But more often than not, you see people who are losing 10 to 15 pounds in a week, week and a half. You know, they're not leaving their room to eat. P, what we refer to as psychomotor. We call it psychomotor retardation, which is just a fancy term for someone whose cognitive skills or their thinking has slowed down. They're not able to be as mentally sharp as they may have been before entering this depressive episode. Although that's the whole list of depressive symptoms that you may see, you don't have to see all of them to really have depression.
Or you can see other things, such as someone coming into my office with chest pain.
Yes.
Chest pain being a somatization, or it's the body's way of trying to show the depression. As we've always said, it's like you're a teapot on the stove,
Yes.
and that it's boiling and the steam is trying to get out and it's whistling. You need to figure out that way to open up the cap and get the steam out. It's the person coming in with palpitations, the person coming in who has lost weight or has gained weight. And the biggest problem about mental health is it's usually not the person themselves that sees it. It's their caregiver, their partner, their boyfriend, their girlfriend. And mental health starts early on, can start early on in life. And in the elderly, we see a lot of depression because of family loss. They're by themselves. They can't move around. And one of the big things is when they get to be in their 80s, the loss of the ability to drive a car. And so someone feels like that, and what should we do?
Well, it's when someone's in an acute episode, of depression or anxiety, what Dr. Uppal has explained and what you have been talking about is it's not always clear cut as to what's going on. I on a daily basis, I have people coming through my unit, and we try to figure out what's going on with this individual. And reaching out for help is important, but most of the time the individual doesn't have the insight or the energy to do that. They know that something's not right, but they don't know what it is or where to go to get help. I'll get people calling and saying, hey, I just need to come in and talk to someone. Well, if that's the case, there's counseling services, there's things, but people don't know that. People don't know what resources are available out there. And oftentimes people are presenting in differently than what you would say is your typical depression. For instance, women are diagnosed with depression more often than men are. it doesn't mean that there's more women that are out there that are depressed. It means that the symptoms are showing differently in the two genders. All right. So our society makes it okay for a woman to show that she is upset in what we consider traditional being upset. Men, they tend to have anxiety and depression show in anger and rage. So people look at that and they're like, oh, they have an anger management issue. Well, that's not really what's going on. This person's depressed, and they need to see a professional to get treatment for that. So there's a lot of things moving parts that go along with this, and it's really, reaching out. There's a lot of different helplines for different backgrounds. You've got cop to cop, you've got warrior to warrior, you've got the warm lines, you have the hotline for teens, and oftentimes reaching out to them, they can get you linked to the services that you need. The other thing is just coming to the emergency room. There's going to be someone that can be linked to, whether it be a therapist, a social worker, or a psychiatric screener. That will be able to interrupt the crisis, talk to the individual, and get them linked to the appropriate level of care.
Well, the important thing at Robert Wood Johnson University Hospital, Somerset, in the ER department, is how well it's put together. The number one reason for people coming into the emergency room is chest pain, and most of the time the chest pain is not cardiac. It's more due to mental illness. And so once the physician has ruled out the cardiac condition, we now have, again, what you do. You have all of the professionals there who can now first diagnose, consider treatment, and then aftercare. And again, it's a whole collaboration that allows it to be done.
Correct. Yeah.
So we talked about depression, anxiety, symptoms of anxiety.
Anxiety can, oftentimes what we see is like racing thoughts, this
constant sense of danger, continuously worrying, racing thoughts, restlessness, very similar to depression. You have the weight gain, the weight loss. So,
well, as we know, the scale here of anxiety, depression, people can have a combination of both of them.
They tend to go hand in hand
Very often they
because
do.
they can become depressed that they're anxious and vice versa. Yeah, and then also with the anxiety, they may experience panic attacks. And then that can really exacerbate the anxiety because what will happen is someone will have anticipatory anxiety about having anxiety, and that can really limit their quality of life.
Now, when we get back to men and women, men are told, don't cry, which again, and they're taught that, and that's socialized in the American society, so they can't release those depressive symptoms, and then they get the anger and the anger management. The other thing is that men don't come to doctors in the number the way that women do. And women are more talkative than men are when they come in, so they can actually explain themselves while most men don't explain themselves. And it's usually the wife that calls me beforehand and says, this is what's going on in case he doesn't tell you, that allows us to make that diagnosis. Now, tell us about the behavioral health services that Robert Wood Johnson University Hospital offers.
So the service that I oversee is the crisis center at the emergency room at Somerset. It's an extension of the emergency department, but it's run by the behavioral health department. And what we're working with are individuals that are coming in and are presenting, like you said, maybe they show for a somatic reason, but really what's going on is that there's some type of underlying mental health that needs to be addressed. So we work in collaboration with the emergency room doctors to make sure that first off the person's medically stable, and then we see them. Now what we're doing is we're doing an assessment. We're trying to figure out, does this individual meet criteria for an inpatient level of care, or can they be discharged and linked to services in the community? And what we do is we have, they're all licensed clinicians, behavioral health nurses, mental health techs, and peer support that all work together with a psychiatrist to determine, is this individual safe to be discharged? If they are, what level of care do they need? And if they aren't, are they able to go into the hospital? Do they meet criteria? And really what hospitalization is you're looking at stabilizing the individual and, starting that treatment. Oftentimes, my unit is the first interaction that anyone has with the mental health system. So it's very unique that we have this. Oftentimes, this is a crisis center, which is different than a screening center, where we're one of the few hospitals in New Jersey that has, we have a couple sister hospitals that have a crisis center, which is a little bit different, and it tends to really focus on making sure that you can get the person the level of care that they need.
And if they are found, to meet criteria and you are going to hospitalize them for acute stabilization, we have a 16-bed inpatient ward on the 5th floor. They participate in groups. We have groups anywhere from 4 to 5 times a day addressing different types of topics. We have art therapy. We incorporate music into the therapy groups as well. We incorporate coping with some of the triggers for the anxiety, whether it's a situation at home, whether it's another social stressor, whether it's a job stressor, just getting to the bottom of what the triggers are and how they can better cope with it, and setting them up with the outpatient, which is where Wagner comes into play.
Yeah, and so we have a partial hospital program, and that's 5 days a week, 5 groups. It will start 9 in the morning until 3:15. And in those 5 groups, they'll be learning, similar to the inpatient groups, coping skills, solution focus, family interventions, anger management that William discussed earlier. And then what can happen is if the person doesn't meet that level of care, then we can step down to an IOP. That's an intensive outpatient program. That's 3 days a week. Monday, Wednesdays, and Fridays, usually people will attend. And that's from 9 to about 12:15. And same thing, it's a group modality, and it's very therapeutic because here you are in the group where people understand you, they get you, and it can be very, very helpful for the person's recovery because they no longer feel alone with these symptoms.
IOPs are terrific also because you can hear what other people have gone through.
Absolutely.
And you can actually see, oh, this is what they did, and maybe that same coping mechanism will work for me.
Absolutely.
Alcoholism, again, has a lot of IOPs afterwards in order, AA, things like that are very similar. Of course, that's only a little short group, at least the IOP, they're there for 2-3 basically days. It allows them to still be on the outpatient and allows them to hear coping mechanisms that others have used that they can incorporate into their own lives.
Yeah. Number one thing I've heard is most of the patients will tell me is that it gives them the sense of feeling that it's okay to feel this way, that there are other people out there that may not be experiencing the same exact thing, but they may be in the ballpark of they may have some type of depression, they may have some type of anxiety, that it's not necessarily taboo to feel that way or to talk about it. And that really gives a lot of our patients a sense of comfort.
Getting rid of that stigma that depression is, I just lived through it. It allows them to say that I have depression, or I have anxiety, or I have postpartum depression, or I have this. And I understand that I'm going to have this for the rest of my life, but I will be able to deal with it through help.
Yes.
And that's, again, and then if I have an exacerbation, I can contact I can contact the behavioral health people. In fact, I don't have to go through the emergency room. I know there's a change. I can contact my therapist. I can contact my licensed social worker who does the therapy and get back. Maybe I need more therapy. Maybe the licensed social worker will say, maybe I need a medication, which I haven't needed in the past. Medications are helpful. Again, in depression and a bad major depressive episode, people may need a medication. And I give medications for diabetes. There's nothing wrong with that. So if someone has depression or anxiety, there's nothing wrong with taking a medication that treats the disease. Postpartum depression, big in the news. Any information for women?
So what we know about postpartum depression is that First of all, what is postpartum depression? What are some of the symptoms? Some of the most common symptoms tend to be that the mother may have feelings of inadequacy. She may feel that she's not able to take care of the baby the way that she's not a fit enough mother, if you will. Some of the symptoms may be that the mother feels that the baby is getting a lot of the attention, that maybe she's not as important anymore, right? Other symptoms, you can just have the depression that comes along with depression, the decreased sleep or increased sleep, the interest and all that type of stuff. What we do know is that if someone has had an episode of postpartum depression in the past, which can last anywhere within 3 to 6 months, they are at increased risk of having it again. And we do know that there are medications that are safe to be taken during pregnancy, and there are medications that are safe even when breastfeeding the baby or the infant. So all the studies that we have shown that it's safer for moms to be on medication while they're pregnant and while they're nursing than it is to not be on medication and to worry about the possible side effects that you may have from the medication.
Which is so important for the primary care doctors to know, to get the people over to the psychiatrist who understands that, who's able to deal with that and to help that woman.
We also actually have groups in our hospital, postpartum groups that get together as well in the evenings from time to time. And we have somebody in our department, Elizabeth. Yeah, and that's what she does. That's what she works with. She is very well ingrained in that. And I've had a lot of the moms tell me that they benefit quite a bit from that group.
Which again brings us back to the fact that Robert Wood Johnson Somerset Hospital Hospital has the leadership that understands how important mental health is. How it's not just the physical health of the person that's maybe causing the problem or maybe making them feel the way they are. It's the mental health part. And the fact that we have a crisis intervention department at Robert Wood Johnson Somerset, which is so different than other community hospitals, allows them to be treated in their own community and have follow-up afterwards in their own community. And the fact that you lead such a wonderful department that does these for people, that you allow their lives to come back. People who have depression will tell you they don't feel like they're living anymore. And the biggest concern we have is, are they going to hurt themselves? And with your understanding, with your help, with your support, with your groups that you have, you get them back into living. How do the people get into it if they want to, without going through the emergency room?
Oh, sure. Well, we have an access line where they'll be able to call and just schedule an appointment as if they were going to schedule an appointment with a dentist. And we would have them come in and they would meet with the social worker. We would do an assessment, evaluate what their symptoms are, and if they meet the level of care, do they need an IOP or a PHP? And if we find them that they do meet the criteria, then we would admit them into the program, and the program would last anywhere to about 6 to 8 weeks. And again, it's collaborative. They can get better much quicker. They may not need the whole 6 to 8 weeks, or they may have to stay an extra 2 weeks. So it may go to 10 weeks, depending on where they're at.
But the fact is, there's a way to get some help.
Absolutely. The door is always open, and I always tell people that just because they're graduating from the program, if they need, like you were saying earlier, a tune-up, I say, call us back. You don't have to go to the emergency room. That we're always there for you. So that's absolutely.
And if there is anyone wondering how to access this line without necessarily going to the ER or having to worry about going to the ER, and they think that they may not need to be in the hospital, a line to contact is 1-800-300-0628, which is our access line.
Can you say that number again?
1-800-300-0628.
Okay, so this way someone can access it or a caregiver can access it and start the process. And it doesn't necessarily mean they're going to be admitted to the hospital. Correct. It means they're going to get the help that they need. Right. The help and as many people know, insurance companies really do not help with the mental health part of this, but at least since this is part of Robert Wood Johnson University Hospital Somerset, most likely this can at least be covered by their insurance.
Absolutely.
They can get the help they need, and they can get the help when it's necessary.
Mm-hmm. Yes.
So, any last thoughts?
While we still have ways to go in defeating this stigma of mental health, I would like to say I think we see more and more people making strides every day in terms of seeking care. And I say that for all the different ethnic groups because there are a lot of cultural values that go into the stigma of mental health. And I can say from our traffic in the ER, in addition to what I see in the community, that more and more people are starting to understand that it is okay to get mental health care. And as you referred to before, you're taking medications for diabetes or hypertension. This is a medication for whether it's depression, whether it's anxiety, and also keeping in mind that just taking medication by itself is not the most optimal treatment. Getting therapy in addition to medication has consistently shown in all the studies that we've seen the best way to defeat anxiety or depression is through that.
That way, when you see your primary care doctor, if they want to do a medication, please ask them to give you the phone number to get into a mental health therapist or find a mental health therapist. Thank you all for being here, and thank you all for helping in the mental health of our patients.
Thank you.
Thank you.
This concludes today's episode of Robert Wood Johnson University Hospital's Health Talk. Please remember the opinions expressed here by our medical experts are not a substitute for medical advice from your own physician. If you need a physician, please call us at 1-888-MD-RWJUH. For more information about the behavioral health services at Robert Wood Johnson University Hospital, Somerset, please visit us at www.rwjbh.org/Somerset. Thank you all for being here. And one last time, that phone number?
1-800-300-0628.
Thank you.